We are back with another series. Let's revise PYQs. This will benefit you in your upcoming exam. Let's look at the first question from this video. Question 1. A defect in which of the following forms the structure marked below? Your options are, and the correct answer is fascia transversalis. Here's the explanation.
What is deep to the transverse abdominis muscle? Transverse abdominis muscle. Deep to that is a fascia. Which fascia? That is the transversalis fascia. Can you see a defect in the transversalis fascia? That defect in the transversalis fascia, deep to transverse abdominis muscle, is a deep inguinal ring. So, deep inguinal ring is a defect in the transversalis fascia for what? To let the testis come. And now what is coming? The spermatic cord is coming into the inguinal canal.
Question 2. A student had his jaw locked while yawning. Which of the following muscles attached to the articular disc of the temporomandibular joint is under spasmodic contraction? Your options are, and the correct answer is lateral pterygoid. Here's the explanation.
But if we are talking about opening the mouth, then one muscle which you should remember working for depressing the mandible is the lateral pterygoid. So lateral pterygoid along with some other muscles which could be suprahyoid or infrahyoid can pull the mandible down on hyoid bone. Can you name the two suprahyoid muscles we have talked about attaching to mandible bone and the hyoid bone and depressing the mandible to open the mouth? The mylohyoid muscle and anterior belly of digastric, helping the lateral pterygoid for depressing the mandible and helping us to open the mouth. Then which muscles are working for the protrusion of the mandible? Protrusion, we have seen it was an accessory activity of lateral pterygoid, and along with that the two muscles, the masseter and the medial pterygoid, they are also working for protrusion. But lateral pterygoid, the first action should always be mentioned as depression of the mandible. For depression, it might be doing a little bit of protrusion, and similarly masseter and medial pterygoid.
Question 3. A defect in which of the following pharyngeal arch artery causes the defect shown in the image? Your options are, and the correct answer is left sixth. Here's the explanation.
The sixth arch artery may be on the right side or on the left side. They are contributing to the pulmonary arteries. As evident in this diagram, maybe the right sided pulmonary artery or the left sided pulmonary artery. And here we need to remember the sixth arch artery also contributes to what is called as ductus arteriosus. May it be on the left side as evident here, or may it be on the right side. But then the right regresses and left is left. So maybe we do have a ductus arteriosus on the right side, but right regresses and left is left. So we will have the ductus arteriosus present only on the left side. But as such, the ductus arteriosus is also derived from the sixth pharyngeal arch artery as we have discussed.
Question 4. Which nerve is most likely to be damaged if a patient who had surgery for varicose veins now presents with sensory loss in the medial aspect of the leg and foot? Your options are, and the correct answer is saphenous nerve. Here's the explanation.
Saphenous nerve. So this is the saphenous nerve which is going to enter the adductor canal and not the femoral nerve. So femoral nerve is a content of the femoral triangle only. The nerve which is a content of the adductor canal is the saphenous nerve. Remember, saphenous nerve is the longest cutaneous nerve of our body, and it is a content of adductor canal but leaves the adductor canal at the roof, piercing the roof, and then moves towards the medial side of the ankle and the toe. It has to supply the skin there. Now, if saphenous nerve leaves the adductor canal, then which nerve do we find in the popliteal fossa? It is actually a nerve which passes behind the tibia. It is called as the tibial nerve. So in the popliteal fossa, the nerve which we have got is the tibial nerve. Hence, it becomes evident that each compartment has one individual nerve. In the femoral triangle, you have the femoral nerve. In the adductor canal, we have the saphenous nerve. And in the popliteal fossa, we have the tibial nerve.
Question 5. The structure marked in the image below gives rise to which of the following structures? Your options are, and the correct answer is falciform ligament. Here's the explanation.
You will see that on the anterior abdominal wall, you are having a falciform ligament, which is a double fold of the peritoneum coming from the umbilicus region and going towards the lever, is carrying the left umbilical vein to the lever. So, falciform ligament is a double fold of peritoneum on the anterior abdominal wall. Yes. And carrying left umbilical vein to the lever. Yes. What is the adult remnant of left umbilical vein? Left umbilical vein would have become ligamentum teres in the adult. And who is carrying ligamentum teres in the adult? The same falciform ligament to the lever. So ligamentum teres is also carried by the falciform ligament towards the lever. Yes.
Question 6. Identify the cartilage given below. Your options are. And the correct answer is white fibrocartilage. Here's the explanation.
In fibrocartilage, as the name is suggesting, more of fibers and less of chondrocytes. And these chondrocytes in lacuna are running in rows. You will find 1, 2, 3, 4, 5, 6, 7, 8. So, like this, another row is here, and interspersed between the rows of the chondrocyte will be long wavy bundle of fibers. We can draw them here. Long wavy bundle of fibers, which is atypical cartilage, so type 1 collagen fibers, and interspersed between these collagen fibers are the chondrocytes running in rows. One row of chondrocyte here in fibrocartilage and another row of chondrocytes here in fibrocartilage. And this collagen is type 1 collagen, predominantly like bone. This is atypical cartilage, the fibrocartilage.
Question 7. A 7-year-old boy was brought to the hospital with multiple fractures of the humerus secondary to a fall from height. On examination, there is difficulty in flexion of the elbow and supination of the forearm and associated loss of sensation over the lateral aspect of the forearm. Which is the nerve most likely to be injured? Your options are. And the correct answer is musculocutaneous nerve. Here's the explanation.
And it is the lateral cord, which then continues as the musculocutaneous nerve to supply the 3 muscles in the arm region before it becomes a cutaneous branch. So, which 3 muscles? We have learned that there is a muscle coming from coracoid process to the brachium, the coracobrachialis, and then it is supplying the biceps brachii, may it be the short head or the long head, and it also takes care of the brachialis muscle then. The root value of musculocutaneous nerve is C567, and as we have discussed, if there is a lesion like Erb's palsy where C5-6 are compromised, C7 was still working, and that is where we mentioned since the coracobrachialis muscle has all the 3 root values C567, it may not be paralyzed in Erb's palsy. But since the C5-6 is the major root value for biceps brachii as well as brachialis, both were compromised to a greater level and leading to difficulty in elbow flexion. Not only elbow flexion but also difficulty in supination, because biceps brachii is a powerful supinator. That is why in Erb's palsy, Polish-man tip hand deformity, elbow cannot flex, remains in extension, and cannot do supination, so remains in prone posture.
Question 8. A patient presented with jaw swelling and weight loss. Suspecting a malignancy, the submandibular gland was resected. Which is the most likely nerve to be damaged during submandibular gland resection? Your options are. And the correct answer is lingual nerve. Here's the explanation.
The postganglionic fibers from the submandibular ganglion will be carried by branches like lingual nerve. The lingual nerve, as the name is suggesting, is going to supply the tongue, and lingual nerve is a branch of the mandibular nerve, branch of the trigeminal nerve, to carry postganglionic fibers towards the sublingual salivary gland and submandibular salivary gland. So in the MCQs will be asked preganglionic fibers to be carried by chorda tympani nerve, branch of the facial nerve, whereas postganglionic fibers to be carried by the lingual nerve, branch of mandibular nerve, the trigeminal.
Question 9. During the clinical examination of the nervous system, which of the following nerves can be tested by touching the highlighted structure? Your options are. And the correct answer is 9. Here's the explanation.
Which is the functional nerve for parotid salivary gland? Then you will say for the parotid salivary gland, the functional nerve is glossopharyngeal nerve, now number 9, as it is carrying the preganglionic fiber. And who is the topographic nerve? Now number 9 is functional nerve. The topographic nerve is TT, trigeminal nerve. It is the branches of trigeminal which will be carrying the postganglionic fibers towards the parotid salivary gland.
Question 10. Which of the following forms the lateral boundary of the anatomical snuff box? Your options are. And the correct answer is extensor pollicis brevis and abductor pollicis longus. Here's the explanation.
So bounded by the 2 extensor tendons is anatomical snuff box. But then anteriorly you'll have one additional tendon. You can actually remember a mnemonic AAA, triple A, Anteriorly, you have additional boundary, and that is abductor pollicis longus. Again, coming from posterior forearm. If you remember, this abductor pollicis longus, the long tendon, extensor pollicis brevis, the short tendon, they were passing through the first compartment of extensor retinaculum, whereas the extensor pollicis longus passes the third compartment of extensor retinaculum. That time we mentioned the anatomical stump box lies between the compartment number 1 and 3.
Question 11. The long left recurrent laryngeal nerve is due to the persistence of which arch artery? Your options are. And the correct answer is 6th arch. Here's the explanation.
Superior laryngeal nerve is the nerve of 4th pharyngeal arch, whereas recurrent laryngeal nerve is the nerve of 6th pharyngeal arch.
Question 12. The type of joint marked in the image below is. Your options are. And the correct answer is synovial. Here's the explanation.
To discuss the structure of a synovial joint, we are taking one example. Say it is the temporomandibular joint. From above comes the temporal bone, and from below comes the mandible bone to form the temporomandibular joint. A magnified view. It is a synovial joint. So you have magnified this area here, and these joints, the upper bone, say temporal bone, and the lower bone, that is the mandible bone, they are held together by one capsule, some collagen fiber connecting the two bones. Now, once you have shown the capsule here, which is connecting one bone with the other bone, it is creating a cavity, and inside the cavity, there will be some synovial fluid. So, synovial joints connected by the capsule, some collagen fibers holding the two bones together, creating a cavity which is filled with synovial fluid, and it is lined by synovial membrane. The synovial membrane is lining the capsule on the inner side, and it will line some part of the articulating bone also. So as you see, this is the synovial membrane here, which is going to line the inner surface of the capsule and part of the bone, as you can see on the other side as well. But we have to understand that the synovial membrane can only line the non-articular surface of the bones participating in joint, because at their articular surface, there cannot be any synovial membrane. There we have what is called as articular cartilage. So let us show that as well. Here, synovial membrane cannot come to this region. This is the region where the bones are in contact with each other, and this articular cartilage, which usually is the hyaline cartilage, is lining the ends of the bone and keeping them smooth, so as there is smooth movement between the two bones in the synovial joint. And we know articular cartilage, the hyaline cartilage, never ossify, though it can undergo degeneration with aging, and there can be osteoarthritis. That all we have discussed earlier. What about this structure here? As we are talking about the temporomandibular joint between the two bones, the upper temporal bone, lower mandible bone, there is one articular disc dividing the synovial joint into two compartments, upper and lower compartment, and this articular disc is working like a shock absorber between the two bones. It is made up of fibrocartilage. So you can show here, this is the intra-articular disc attaching to the capsule and then working like a shock absorber, dividing the cavity of synovial joint into two compartments, one upper compartment, one lower compartment.
Question 13. Which lobe of the prostate is responsible for the formation of the uvular vesicae? Your options are. And the correct answer is median. Here's the explanation.
This is median lobe hypertrophy now, causing bladder outlet obstruction. You are telling this is the median lobe hypertrophy which is causing some bladder outlet obstruction. How? A tongue-like projection. It is sending a tongue-like projection, and that tongue-like projection is called as the uvula vesicae. So this is some tongue-like projection into urinary bladder, because of median lobe hypertrophy, BPH, and causing incomplete evacuation of urine.
Question 14. Foot drop is caused by damage to. Your options are. And the correct answer is common perineal nerve. Here's the explanation.
So if the common perineal nerve is compromised, the two branches, that is superficial perineal nerve and the other branch, deep perineal nerve, will get compromised. And as we understand, there will be three problems now. Which three problems? Number one, the patient will have difficulty of foot eversion. Patient cannot turn the sole outwards laterally. So, loss of foot eversion due to injury of superficial peroneal nerve plus sensory loss, but on the dorsum of the foot, not the sole. That is why in this question, the answer of exception is choice number B. It's a wrong statement. As I said, if you're talking about the sole sensation, it should be injury of posterior tibial nerve, or maybe its branches called medial plantar nerve, lateral plantar nerve, but not the common peroneal nerve lying lateral to neck of the fibula. And what is the third problem? As the peroneal nerve is not working, dorsiflexion is not working, foot drop. And what is foot drop? Inability of the ankle joint to do the dorsiflexion, or what you can say extension. So as we understand, lateral to the neck of fibula, common peroneal nerve has been compromised. Choice number 1 is okay. Then there's a foot drop, loss of dorsiflexion at the ankle joint is okay. Loss of foot eversion due to injury of the superficial peroneal nerve is also okay.
Question 15. What is the basis for the formation of omphalocele? Your options are, and the correct answer is physiological hernia failing to go back. Here's the explanation.
Omphalo means umbilicus. And what is seal? Seal means hernia. So you're telling omphalo is umbilicus and seal is hernia. Umbilical hernia? Yes. Where is umbilical hernia? Let me see. See, this is a normal thing to have omphalocele. You mean to say omphalocele is something which is physiological? Yeah, it is physiological hernia. But if it is not regressing, then it will become pathological hernia. By the way, what is omphalo? Omphalo is umbilicus. And what is seal? Hernia. So you're telling that some midgut has herniated into the umbilical cord temporarily? Yes, because abdominal cavity is small and gut is growing fast. So there is no space inside the abdominal cavity, and temporarily the midgut will stay inside umbilical cord, and later it can come back. So this is a normal physiological umbilical hernia. Yes, physiological umbilical hernia, and the intestine is inside the umbilical cord. And because this intestine is inside the umbilical cord, it is covered by amnion.
Question 16. Which fiber is marked by the arrow in the image given below? Your options are, and the correct answer is projection. Here's the explanation.
Lateral is the lentiform nucleus, as evident here, whereas medially we have got the comma-shaped nucleus, which is the chordate nucleus. Corpus striatum being divided by the internal capsule, making these projection fibers. And the fibers of internal capsule, as we already have mentioned, could be the descending fibers from higher centers to the lower centers, or the ascending fiber from lower centers to the higher centers of brain. So this internal capsule projection fiber has divided corpus striatum into two components. L for L. Laterally is the lens-shaped nucleus, lentiform nucleus, and medially is the comma-shaped nucleus, the chordate nucleus.
Question 17. What is the nerve supply of the structure marked in the image below? Your options are, and the correct answer is median nerve. Here's the explanation.
Now, following the median nerve, we have observed that this nerve is going to pass deep to flexor retinaculum. But before it does that, it has given a branch called as the palmar cutaneous branch. And this palmar cutaneous branch, which is already given before the nerve is going deep to flexor retinaculum, is the one which is going to supply skin on the lateral aspect of the palm, the palmar cutaneous branch. And then the median nerve is passing deep to the flexor retinaculum. As it reaches here, we have seen it will give one recurrent branch. This recurrent branch is going to supply the muscles of the thumb region. So, recurrent branch to thumb muscles. And then it will also be giving the cutaneous branches for the 3.5 fingers.
Question 18. Which of the following is false about skin? Your options are, and the correct answer is dermis is derived from ectoderm. Here's the explanation.
Surface ectoderm is going to form first layer of cornea and the eye lens. The surface ectoderm is also forming ameloblast, the enamel, and surface ectoderm also forms the skin epidermis.
Question 19. First pharyngeal arch gives rise to all except. Your options are, And the correct answer is levator veli palatin. Here's the explanation.
The first arch is giving us maxillary process and the mandibular process. So maxilla bone, the mandible bone, they develop in the first arch. As is evident here, this is the stomodeum or the mouth. The upper jaw is formed here, the maxillary process of the first arch. The lower jaw is the mandibular process of the first arch, superior and inferior to the stomodeum, the oral cavity. The eyes will be developing more superiorly. This is the nasal region depicted here.
Question 20. A patient presents with swelling under the left ear lobule and complains of pain. Which of the following structures is the likely cause of the pain? Your options are. And the correct answer is greater auricular nerve. Here's the explanation.
It is the C2 and C3 together going to form a nerve which is called as greater auricular nerve, as the nerve is supplying greater part of the auricle. And not only it is going to supply the greater part of the auricle, but also giving branch to the skin at the angle of the mandible.
Don't forget to like and subscribe if you found the video interesting. See you in the next one.